We would now go on to Dr. Sourabh Patwardhan, and who was really waited far too long. And thank you so much, Dr. Sourabh. And he definitely needs no introduction, and he heads the Nandeep Eye Hospital and has had so many fellows and so many students coming out, and the kind of YouTube presentations which he has. I think any of us at any age are still learning from him. So kudos to you, Dr. Sourabh, and let's hear your very interesting talk on the challenges in a routine cataract surgery. And following this, since there has been so much of a change of sequences, following this, it will be the unilateral cataract debate, which will be taken up, and then finally the Fuchs with early cataract. So yes, on to you,
Yes.
Doctor.
Thank you very much, Dr. Chitra Madam, for this kind invitation, and it's an honor to give this keynote address. And so far, we have been, I think, seeing all the complexities of complex cases, and my topic will be complexities in a routine cataract surgery. So it is going to be little interesting. So when this topic was given to me, I was just thinking what exactly is mean by a routine cataract surgery. Now, we know what a routine is. A routine is a fixed or a regular way of doing things which is followed consistently over a time. Now, when we say it's a routine or regular cataract surgery, what we mean is that we are expecting very predictable steps and predictable results at the end of it. But sometimes I think the most complicated, because we are doing a lot of routine cases as compared to complex cases, I think overall there will be more complexities associated in terms of numbers with routine cataract surgery than the complex surgeries itself. So just a clip to start. We all of us do this treadmill routinely, but sometimes the routine things becomes little complex when you approach things little differently. So the same routine surgery for us may become little complex if we approach things, little differently. So we'll start with the first experience. So this was a routine surgical, cases, because I always divide my surgical list into a routine cataract list and a complex one. So that I can give adequate time for complex surgeries. So this was part of routine case list, and I was doing, and I heard a commotion outside in the preparation room where we had a patient who was having a kind of a panic attack. The reason was that patient had intense claustrophobia. So patient was suffering from claustrophobia, and that's the reason why he had delayed the surgery for so long, because he knew that the drapes will be put on his head and will be claustrophobic, and already he was with that anticipation, he was having panic attack. So I spoke with the patient. I told him, because these are the cases, maybe I have to take him under general anesthesia or sedation, or to relieve his anxiety. But this was a routine cataract surgery. So I just spoke with the patient. I told him that we'll put the drapes, but your other eye will be always open. My assistant will be holding that drape, up. And whenever you feel like looking around, you just tell me. I will stop the surgery, and you can look through the so once we lift the drape all around, you can just look around and see the assistant. You can speak with them, and then we can go ahead. And this simple step relieved a lot of his panic, and he calmed down, and he was extremely happy at the end of the surgery. So sometimes these kind of incidences happen even with routine cataract case, and we may have to approach them differently. Now, though it is a routine cataract surgery, sometimes we miss important histories. So just showing one more case here. Actually, the audio, I'm not sure whether it will be there or not. I was just starting the case, and the patient started talking with me, saying that this is my second eye surgery, so please do take care. Now, when my assistant showed me the case sheet, there was no history of any previous surgery. So I asked her, it was like 35 to, I think, 37-year-old lady. And she told that she had LASIK refractive surgery done few years back, and she has not told this to her in-laws, and that's why even in pre-operative examination she had hidden that. The keratometry was 3940, so probably that's why we missed it, and we don't do topography as a routine for all our patients. Now already I had planned EDOF for this patient. Luckily, in this case, I had a library. So once she told me on table that she had undergone LASIK. So now I asked my fellow to do the calculation with online calculator and Barrett-Truke formula and find out what is the IL power. And luckily, as I said, I had already the library of these lenses. Otherwise, I was stuck in this case. So luckily, everything went ahead smoothly. But I think missing a important history, because many times we may not ask, or sometimes our assistants or optometrists miss taking a proper history during their examination, so that may lead to certain issues during routine cataract surgery. Now sometimes we miss steps. I'm just going to show you another surgical case where the patient demanded surgery under block. So generally, I do all my surgeries under topical anesthesia, but this patient specially demanded when he came to the preparation room that he wanted block. So my fellow gave the block, and after that, the patient was immediately shifted to OT. So you can see that as I started my capsular access, immediately once I opened the main incision, there was gush of viscoelastic outside, and that was because still the intraorbital pressure was quite high. So normally we don't expect this kind of sudden upthrust when you are doing CCC, but because it was a peribulbar anesthesia which was just recently given, there was no time was given it for it to dissipate. No ocular massage was performed, and straight away, because my earlier surgery was already over, patient was taken on table and draped, and this increased intraorbital pressure led to this kind of upthrust. So all throughout the surgery, there was considerable upthrust. I managed it later by using the small side port incision for doing the capsulorhexis, and all throughout I was little careful. I gave more time for the case to complete. But I think if we miss the steps, so the important message here I realize is that if the fellow or student has given block, they should know that you have to give some ocular massage and wait for certain time before the patient is shifted for the surgery. Sometimes when you are going ahead now, this is another case which I would like to show. I was preparing to take the incision with the side port blade here, and I was about to stabilize the globe. And the moment I wanted to stabilize the globe, the patient just in split second moved the eye away, and that led to, you can see the blade is inside the cornea and just moved and created a very large incision there. So it was much larger than what I had wanted, obviously. And once we have this kind of situation, and this was just a routine cataract surgery, but because of this large incision, now I have to be extra careful all throughout the surgery. Now here we have to think of options what can be done. So difficulties will be, there will be leak expected, and the regular parameters will be risky. So one option can be just suture the incision, make a new small incision, go ahead, or we can do single-handed phaco so that there is less leak around, and you can reduce the vacuum and flow rate. So I went ahead with single-handed phaco. So I tried to use just main incision for most part of the surgery, and only in places where I needed the second incision, I used it. And whenever I was using second incision, you can see that there was quite significant leak there from the side incision. It was quite big side port incision, but by changing the parameters, reducing the phaco parameters, I could manage it in this particular case. But this was a regular case which turned out to be complex just because of that split second patient's eye movement where I had not stabilized the eye. Sometimes we do things a little excessively, trying to make it safer, but in land up with more problems. So this is one of the video from one of my colleague, and he's using the side incision for putting the OVD, and he injected excessive OVD. This was a heavy OVD, so difficult to wash out as well. And with this kind of excess OVD, you can see even the cornea becomes hazy as well as the iris prolapse. So you have to be very careful. Simple excess OVD makes things little difficult and making it more complex. Another case I wanted to just show here, routine case, and one of my colleague decided to inject OVD, but he injected excess of OVD. So otherwise the capsular axis was going fine, though it was little bit on larger side. But the moment he started injecting the OVD and he excessively injected it, it caused deepening of the anterior chamber further. The zonules probably got stretched because of and probably the sclera was not that rigid, maybe a younger patient or a myope. And that led to just tearing of this capsular axis away into the zonules. So just because he tried to, make it extremely safe by deepening the chamber, it in fact caused more problems. Now, another case where small capsulexis is done, first hydrodissection, and then in second hydrodissection, there was excess buildup of pressure in the posterior part. You can see that, and it just caused hydrorupture. You can see that in slow motion that the posterior capsule just ruptured, and this was a very typical pupillary snap sign which was seen. So otherwise, this was just a posterior subcapsular cataract, but hydrorupture resulted in impending nucleus drop, which had to be managed. So a pupillary snap sign in otherwise a regular or routine cataract surgery led to a complex situation which then had to be dealt with. Okay. This was another case from one of my colleague, completed the case, and IL was already implanted. It was just viscoelastic has to be removed and see what was done. So while trying to go behind the IOL, the entire bag was pulled and caused iatrogenic dialysis. So this was just about to finish the case and caused iatrogenic dialysis. Though the IOL was stable in the bag, obviously with larger dialysis, there is always a chance that once the capsule starts fibrosing, the IOL may get decentered. So colleague decided that I will put a CTR to stabilize the bag. I just wanted to show what things went wrong while putting the CTR. So the first eyelet is already inside the bag. Now you have to press this CTR down so that it doesn't, jump into the sulcus. But that's exactly what is happening here. These CTRs are very springy, so you have to guide them into the bag properly when you are using, you're doing a manual injection of the CTR. Now using another grasper to push in the CTR, but the second hand, the Sinski should have pulled the CTR inside and pushed it into the bag, but it was not guiding the CTR, and which means that now the CTR is going into the sulcus. You can see that at this point the surgeon should have stopped but continued and thought that might be able to put it in the bag, but ultimately lost control over the eyelet as well, and that CTR went to the angle. Surgeon tried to retrieve it, but now went into a little bit of panic mode because already there was one iatrogenic complication. So, and this happened. So he called me, and I corrected it. So first thing was to get hold of this eyelet which had gone into the angle, and with the forceps I could find out the eyelet here, and then I pulled out the CTR. You have to be very gradual in pulling this CTR out so that you don't damage the back further. And now I will guide the CTR again back into the bag by using proper technique of CTR insertion. The anterior chamber was again inflated. And now the second hand Sinski has to be properly used to dilate inside the bag. So once first eyelet goes in, the second Sinski should be pulling it, and it's better to use slightly longer Sinski so that it doesn't slip when you are putting the second eyelet inside. Now you can see how I am guiding the CTR right into the bag, and the position is now correct. It is guiding the CTR into the bag, avoiding it to jump out into the sulcus. And at the end, I'm using the grasping forceps to push it in, and then use the Sinski hook to hold the eyelet and then put it in the bag wherever it is needed. So it's important that to avoid iatrogenic complication, obviously the surgeon should have been more careful while going under the IOL. But if you have it, I think you should be able to manage it also well. Sometimes it happens that the surgery is about to end, you have done a good job, and just about to visco wash. So another colleague of mine doing the surgery, there was a small descemet, probably detachment near the incision, which happens very commonly. But here the surgeon withdrew the probe, IA probe, And what happened is that the irrigation started pushing these desmites away, and at the same time, the IA probe held that desmate and caused a big tear. So you can see that. Now the surgeon tried to push the reflux button and release that desmate membrane from the IA probe, but it was not happening. Probably the capsule had not completely occluded the tip. So he had to slowly manually release this desmate. And of course, we have to manage this by putting air inside. And but this was something which was completely unnecessary, just because at the end of the surgery, the surgeon was little bit not mindful of what was happening at the incision site, and that again converted a routine regular cataract surgery into complex one. Luckily, the tear could be managed just with air injection, and patient did quite fine there. You can see the big tear there. So you have to be mindful. Even if it is a routine cataract surgery, you might be doing lots of surgery in a day, but you have to be mindful for each and every step. Now, this is a case where the surgery has been completed. The pupil has come down little bit during the procedure. It's a plate haptic trifocal IOL, which I have to push inside the bag. I thought that I have pushed the IOL in the bag and started with viscoelastic removal OVD there. And when I removed OVD, I realized that the IOL was not centered properly. It was decentered. Now, at this point, always you have to investigate why it is decentered. You should not just close the case at this point. So you have to think why this is not centered, whether it is in the bag or not, if the bag is not stable, or if the PC is not intact. You have to take care of that on table. Don't think that it will correct itself. So when I examined, I realized that the trailing haptics were not inserted into the bag while injecting properly. So that's the reason why the IOL was decentered. Now, if I just close the case, and the patient post-operatively is not going to be happy with the decentered IOL, and I have to take the patient back into the operating room and correct it. So it's always important, before you close the case, make sure that IOL is in the bag, and there is no decentration of the IOL on table. Otherwise, you have to find out the reason and make sure that it's corrected then and there. Okay, Dr. Chitra madam, do I have more time or should I finish here? I can't see. Hello?
1 minute left, sir.
Hello?
No, doctor, if you have, you are ready to conclude, then it's fine too, because we are running late, not because of you, but
Okay.
because of the discussions.
Okay.
And I want a question or two to be asked to you.
Okay, okay, fine. Then last video I will just skip. So that's the end of my presentation.
Wonderful.
Thank you.
Truly
Thank you.
wonderful set of videos it was. And Dr. Meenu, Dr. Gaurav, do you have a question to ask this very eminent surgeon?
He's already given all the answers. He's beautifully demonstrated all the mistakes that can be done and then how to tackle them. So I think very nicely managed, and he's shown a gamut of common complications that we can have. So I could relate to them because these are things that you can commonly do. Only thing was that the last one, the one that we just saw with the desmate, that was quite unique, and it was scary as well. So I was just wondering in my mind, I was thinking what we could have done if reflux was not working, because it's a very tricky situation, and there's little that you can do. It's almost like an IOL which is stuck in the cartridge, and you want to neither can you go forward nor can you come out. And so any thoughts? I mean, I don't have a clear answer. I mean, you did manage it quite well.
So
but
what we did, like this happened to one of my fellows actually when he was operating, and he was stuck there, sitting with the desmate in the IA probe and asking what should I do. So we pushed the reflex button, but as I said, probably the desmate was not completely occluding the IA tip. So that's why even if reflux was happening, it was not getting released. We tried even the pinching the tube also. But ultimately, what he did was with the left hand Sinski, because at this point we cannot take over. He has to manage it himself. So he could release that desmate, and luckily it was intact. So that was fine for us.
So my thought was that if we just kind of disconnected the aspiration from the back end of the thing, somebody who was assisting, that would probably, I mean, I'm not sure, because the infusion
actually it was, I think, more because of the maybe capillary action that it had gone, and because it's very thin. So it's like, got stuck there. So
But anyway, it was
luckily
well
nothing
managed,
happened.
so we got
Yeah.
away with it. But it looked very scary, and it's a good lesson that one has to
Yeah.
be very careful. Another thing which I wanted to add here was that sometimes, if you're pushing, it happened to one of my consultants who was operating and, in a glaucoma surgery from a side port, she pushed towards the, end of surgery. She was pushing from the side port viscoelastic to form the chamber, and it caused a big DMD.
Yeah. Yeah.
It went across and a whole inferior, temporal to inferior DMD. And then there was viscoelastic under the DM. It was crazy how to handle it. We did like 3 attempts at kind of doing it. So, I mean, sometimes you have to be very careful when pushing any fluid or viscoelastic from side ports, that we end up trying to push it like almost like hydrating the wound. But one has to be very careful that you don't end up creating a DMD at that time as well.
Yeah.
Actually, in
So
particular
I
case
had
of
one.
the tear in the DM, I actually wondered how an air bubble alone sufficed. Maybe you could have needed a more long acting like a C3FA. You
Yeah,
were
because it was a superior, basically the fellow was doing a superior incision, so the air luckily was enough for this patient.
Yes, Dr. Meenu, you
Okay.
have something to
Yeah,
add?
Saurabh, as usual, these are all things which happen to all of us, and you have rightly shown them how to manage and all those. So, what about when you do cortex aspiration? I do. This is things which are happening to me also. So, when you do cortex aspiration, and especially when this 7 millimeter, 6 millimeter pupils come down a little bit, and we have a tendency to go towards the equator and aspirate, and you maintain the high vacuum. Most of many of the time, we don't go down much when you're finding small bits and all there. Don't you have you caught equator and pulled just like the ones which was manually pulled by catching inside the equator
Smallness of it.
Yeah.
when you're aspirating a little bit of cortex here in the peripheral?
Yeah, yes, I think all of us have done that. But I think one very good trick, which probably I have seen Dr. Vasavda sir doing, I don't remember, but I have in one of my videos. I use generally coaxial IA. And when we are doing the cortex aspiration, the trick not to hold the capsule is pull it posteriorly and not centripetally. So if it's only a small, distance you travel with your probe, but you don't pull it centripetally, but pull it down. So what it does is that it gives fluid a chance to go underneath and the cortex get released, and you are also away from the capsule. So chances of catching hold of the capsule is quite less. So I think that avoids whenever you are doing very fast cortex aspiration, this is what I do. So I hold the cortex and pull it down rather than centripetally.
In the second, one more thing is as Gaurav was telling about the hydration of the paracentesis. Sometimes when I do hydration, the side port gets quite white, and then you don't know exactly where you are, and you see that it is leaking again. And if you hydrate again, you don't know where the location is. And I've had one or two fluid waves going around partially. Suddenly when the fluid comes on, I stop, but then still after it gets hydrated. And the second thing is I have stopped long back when I was PG itself. I have had detachment by pushing visco from outside the paracentesis. So at that time itself, I stopped pushing visco from a large cannula by keeping it on the outer lip of a paracentesis. Without going into the anterior chamber, I do not do that at all.
I think Dr. Naren has some question, Dr. Chitra. He was raising his hand.
Yes, Dr. Naren. Yes.
No. Just a small comment about actually the wonderful videos as usual. Just a point on that, where the DM got stuck in the cannula. I think one simple tip is you remove the tube, and then even though the what do you call it, the syringe doesn't fit into that hole, the assistant can just flush it along that hole. That some amount of fluid will push out the DM. That I think would really help in such scenario.
So I think next time if we have this, this was a unique situation. Luckily, the fellow held the probe just like that for at least for few minutes till we try different things. Most of the times, somebody will just pull it out and entire desmet is out with that probe. Yeah. So luckily, he didn't do that.
Can I ask a quick question, ma'am? 30 seconds.
Yeah, 30 seconds because we are really late. I have two sets.
Yeah, I'll finish in 10, ma'am, and leave the rest 20 to Saurabh to answer that.
Yeah.
Saurabh, one of your wonderful videos, I agree with all the panelists here. One of your cases, a side port extension inadvertently that was caused due to the patient eye movement, and then you created the main incision again and largely did not use the large side port incision. Could you have used the enlarged side port incision as the main incision and not construct another main incision at all to complete the case, and yet you use the more bimanual technique? Maybe change the sleeve to a 2.81 just to fit into the extended side port incision and use that as the main one?
Yeah, it was a quite old video, but it was very large, almost 4 mm large extension. So I could not use that. I thought of that at that point, but it was also very short incision, so it would have leaked even if I had used. But yeah, if it is exactly 2.8, if I can, by mistake make it, then it was a good idea to use that.
These accidental incisions are very shallow, so difficult. It wouldn't be a proper wound construction. Thank you very much, Dr.
Thank you.
Sourabh. And,